Hello everyone. Today we'll talk about the topic of RPD, that is major connector. So major connector is one of the component of RPD, and today we'll talk about major connectors in RPD. Before starting the major connector, I would like to tell you about the um, other components of the RPD in brief. These are major connector, the main connector, or the major component of RPD. Now, the major connector is the component which connects one arch to the other arch. The components which are present on one side of the arch are connected to the other side of the arch through major connector. The other component is, or the second component is minor connector. Now, as we can see in this figure, the minor connector is the component of the RPD which is connecting the other components of RPD, the other small components of the RPD to the major connector. So the function of the minor connector is to connect the other components of the RPD, for example, direct retainer, rest, or the denture bases to the major connector. Now rest and rest seat. Rest are the components of the RPD which are present in the rest seat. Rest seat is prepared in the abutment tooth, and on the rest seat we give rest. Rest basically helps in providing support to the prosthesis. Now what is support? Support is the property or the characteristic of the prosthesis in which it resists the vertical force towards the tissue. So that property is provided by the help of rest. Then comes direct retainer. As the name suggests, direct retainers helps in providing retention to the RPD. Next is indirect retainer. So indirect retainer are also basically rest. There are two types of rest: primary rest, which we have discussed before, which provides support to the prosthesis, and the indirect retainers are basically secondary rest or auxiliary rest, which helps in providing the indirect retention to the RPD. What they do, they help the direct retainer to provide the retention. So that is why they are known as indirect retainers. Now the next component is a denture base. So as the name suggests, it is the base or the foundation of the denture. Now on this base, we put artificial teeth or we arrange artificial teeth. So this base will act as a support for arranging the artificial teeth. And all of us know the function of artificial teeth. These are the teeth which are replaced for the missing teeth. So these artificial teeth can be of acrylic. Mostly acrylic is used, but we can also make artificial teeth of porcelain or metal. Now out of these all components, today we'll talk about major connector. So as we have already discussed the definition of major connector, I would again like to tell you about the definition according to Glossary of Prosthodontic Terms 8. Now, a major connector is the component of the partial denture that connects the part of the prosthesis located on one side of the arch with those on the opposite side. Now, there are various functions which a major connector performs. The foremost and the major function is that it performs unification. Unification means that it unites all the components. It unites the components of one side to the components of the other side. So that is what unification means. Now the other function is uniform distribution of the applied force. Now from where this force is coming? This force is coming due to mastication, due to speaking, due to smiling, due to swallowing. So whatever the force is applied to the prosthesis, that should be uniformly distributed throughout the prosthesis. If only one side of the prosthesis is getting uh, um, force, then that bone or that mucosa will be harmed. There will be more resorption on that side of the part of the denture bearing area. So to avoid this, what we want uniform distribution. So with the help of major connector, we can achieve this uniform distribution of the force which is applied to the prosthesis. Next, it helps in the minimization of the talk to the teeth, and it also provides cross arch stabilization. Now, what is cross arch stabilization? This is the property which is provided by the RPD only. This property cannot be provided by FPD. So, this is the major advantage of RPD, that it stabilizes both the arch. For example, if a tooth is missing in right side of the mandibular arch, then FPD will only stabilize that side of the arch. That is only the right side of the arch. It won't stabilize the left side of the arch. But in RPD, the RPD will extend to the left side as well. That is why it will stabilize both right as well as left side. Now the ideal requirements of the major connector. First, it should be rigid. Now, why it should be rigid? It should be rigid for uniform distribution of the force. As we have discussed that major connector ka the major function is to distribute the force uniformly. So that can only be done if it is rigid. If on the other hand, if we will provide a flexible RPD, then the part on which we will apply the force, the whole force will be concentrated on that part only, and there will be more resorption of the bone. So we don't want one part to be more stressed and the other part to be not to be stressed at all. We want uniform distribution so that there is minimum bone resorption overall. For that, we need a rigid major connector. The second requirement is that the major connector should not impinge on the soft tissue. Now for this, the superior border of the maxillary major connector should at least be 6 mm away from the pregingival margin. And the superior border of the mandibular major connector should at least be 3 mm away from the from the pregingival margin. So if they'll maintain this much of distance from the pregingival margin, there will be no impingement on the soft tissue. Secondly, it will be easy to clean these areas and to maintain hygiene. So that is why this property should be there in major connector. Now, the borders of the major connector should always be parallel to the mean marginal line. And if they cross this pregingival margin, if they have to cross the pregingival margin, then it should always be at right angle. Secondly, it should not allow any food lodgement. The other requirements are that this major connector should provide vertical support and indirect retention. We have already, I have already told you about the indirect retention. Secondly, it should also provide the vertical support. Vertical support is again the same support which we talked about rest, that it should not allow the impingement of the or movement of the prosthesis vertically towards the tissue. It should enable to place the denture bases, as the denture bases will be placed over this major connector. So that property should always be there in major connector so that we can arrange teeth over it. It should be comfortable to the patient, and the major connector should always be made with a biocompatible material. That is, it should not be toxic, it should not be allergic to the biological tissues. Now, selection of the major connector. So there are mainly two factors which help us to select the major connector. The first factor is support and the second factor is rigidity. The major where we need, now it depends on the clinical situation, where we need more support and more rigidity, where we need less support and less rigidity. As a rule, when a edentulous area is small, then we need less support, we need less rigidity. But if the edentulous span is long, it is more of the teeth are missing, then we need more support and more rigidity. So in according to this, we can choose that which major connector is suitable for which situation. If there is less support and less rigidity needed, then we can use the major connector which provides less support and less rigidity. If we need more, then we have to choose accordingly. Now, support is provided by natural teeth as well as by hard palate. As I've told you that if there is uh, short or small edentulous area, that means if there are more natural teeth present, then automatically support will be more. So we will get the support from natural teeth. We don't need major connector to be more extensive to provide support in this case. As well as in the hard palate, if we are covering, if there are more natural teeth, then we need to cover less of the hard palate with the major connector, or we need less support from the hard palate. But if there are less natural teeth, then we need more support from the hard palate. For achieving support from the hard palate, we need to extend major connector on the hard palate. Now, rigidity is enhanced by the design of the major connector. The major connector, which are usually made with anterior and posterior bar, and these bars are, if they are connected to each other, then they provide L beam effect, which makes it more rigid. So, designing of the and design and the material of the major connector makes it rigid. So if it is providing L-beam effect through its design, it will be more rigid. If it is not providing this L-beam effect through its design, it won't be that rigid. In further slides, I will be discussing with you that which major connector provides L-beam effect and which major connector does not provide this L-beam effect. Now, for the mandibular major connector, rigidity is usually obtained by thickening the inferior border of these major connector. Now, lingual bar and lingual plate are commonly used mandibular major connector. So, if we thicken their inferior border, then we can have more rigidity. But thickening of the borders automatically have some disadvantages. They also have some disadvantage, that is thickening will increase the bulk of the major connector and overall prosthesis, which can be uncomfortable to the patient. Now it is a small chart which gives a summary of that which major connector provides more support and more rigidity, and which major connector does not provide much rigidity and support. For example, posterior palatal strap and complete palatal plate will provide excellent support and excellent rigidity. Now the reason is that both of these major connector covers most of the hard palate through their design. And as we have already discussed, that more coverage of the hard palate means more support and as well as more rigidity, because covering the hard palate will even give a design which will provide L-beam effect. So that is why these two major connectors will provide more support and more rigidity. Other major connectors like anterior palatal strap, anterior posterior palatal bar, or posterior palatal bar are poor for support and rigidity, as they don't cover that much of surface area. Now, the other consideration for selecting a major connector other than rigidity and support can be the residual bridge tissues, the remaining occlusion, whether tori is present or not. Now, here I want to emphasize that if a tori is present on the hard palate or on the lingual vestibule, then we have to avoid the major connector, uh, which is over these tori. We have to bypass the major tori. So we cannot choose the major connector which is covering these tori, because if we cover the tori with major connector, especially the larger toris, then it will cause trauma to the patient, as well as they will be acting as a fulcrum point, and your prosthesis will rotate around or move around this tori, move over this tori, I must say. So that should be avoided. Therefore, the coverage of the tori has to be avoided. Or we can go for surgical excision of the tori, and then we can give our design of major connector. Now, attachment of the tissue of the floor of the mouth again influences the selection of a major connector. If the attachment is too high, then we cannot choose the major connectors. This attachment of tissues of the floor of the mouth will only affect the selection of mandibular major connector. So if a mandibular major connector needs more space, and if the attachment is high, then we cannot use this. Then we have to choose the major connector. We cannot use that major connector which needs more space for placement. Now, to start with maxillary major connector, the first type of maxillary major connector is single palatal strap. Now, this is the major connector from here to here. So this is single palatal strap. The width of this major connector is very less. It is only about 5 millimeter, 5 to 8 millimeter. So it cannot be used in long edentulous area. It is only indicated in Kennedy's class 3 situation. Now, Kennedy's class 3 situation is a situation in which edentulous area is present or bounded by anterior teeth as well as by posterior teeth. So it is only indicated in class 3 situation. It provides minimal rigidity as well as minimal support. It is not good in providing rigidity and support, but it is very much comfortable for the patient. Now, comfort depends upon the upon the coverage of the heart palate. Less coverage means more comfort to the patient. More coverage of heart palate with the major connector will lead to less comfort to the patient. So as the coverage is very less, so the patients are very comfortable with this major connector, and it is mostly accepted by all the patients. Next is single broad palatal major connector. Now, this major connector is also known as complete palate major connector, as it is covering whole of the palate. It covers whole of the palatal area, and it provides maximum rigidity and maximum support. As it is providing maximum rigidity and maximum support, this can be used in long edentulous areas or in the challenging situations such as Kennedy's class 1. Now, Kennedy's class 1 is a situation in which edentulous area is present, is bounded by the teeth only anteriorly. Only anterior teeth are present. No posterior teeth is present in this case, or no teeth posterior to the edentulous area is present. And Kennedy's class 1 situation is a bilateral situation, bilateral edentulous situation. It can also be used in the cases where the palate is U-shaped or V-shaped. But the only contraindication is that there should not be any tori. If tori is present in the maxilla, and the common situation, the common location for the tori is the center of the heart palate. So if it is present at the center of the heart palate, we cannot use this design, because if we use this design, it will cover the tori and it will give more, it will be traumatizing to the patient, as well as the prosthesis will also move over the tori. So it cannot be used with the tori, as it is covering most of the hard palate, so it is least accepted by the patients. Here also we can see in the picture that it is covering most of the hard palate. Now next is combination of anterior and posterior palatal strap. This is the anterior palatal strap and this is the posterior palatal strap, and these palatal strap and posterior palatal strap is connected by two vertical straps again. So this is basically is also known as closed horseshoe shaped major connector, and because of this design it provides excellent L-beam effect. So as it provides excellent L-beam effect and it is covering hard palate also, major portion of the hard palate, it provides excellent rigidity and excellent support to the prosthesis. So it is indicated in almost all naturally partial denture design and is better accepted by the patient as compared to complete palate, because the middle portion or the center portion of the palate is not covered. So it is accepted by the patient as well. The other major connector is U-shaped palatal connector. Now, as we can see in this figure, this is U-shaped palatal connector, and the posterior bar is missing over here, as we have seen in anterior posterior palatal bar. So it is covering less amount of hard palate. There is no L-beam effect also because there is no posterior bar. So this will not provide much rigidity and much support, but it is indicated in class 4 situation, Kennedy's class 4 situation. Now Kennedy's class 4 situation is a situation in which the edentulous area is bounded by teeth only posteriorly. It is also a bilateral situation and the teeth are only present posterior to the edentulous area. But this design can be given in class 4 as well as in the cases where tori is present. If there is a tori present in the center of this palate, like here, then we can give this design because it won't interfere with this tori and it won't cover with this tori. So here in these situations we can give this design, but we should be careful that we should avoid this design, or this design is totally contraindicated in Kennedy's class 1 and class 2 situations where we have to replace the posterior teeth. The reason is that if we replace the posterior teeth with this design, and as soon as the force will be applied, there will be flexion in this major connector. So to avoid this flexion, we should avoid this type of major connector in replacing posterior teeth. So it is contraindicated in distal extension cases, but it is accepted well by the patient because of less coverage of the hard palate. Next is single palatal bar. Now, as we can see that single palatal bar is a small thin bar which is crossing the hard palate from right side to the left side. It is hardly 5 millimeter in thickness, and it is only given in the situation where we need to give the prosthesis for temporary use or for interim use for few months, like 2 to 3 months, till we give the patient, till we restore the patient with permanent prosthesis. There we can give this type of major connector for some time, as it provides really very less support and less rigidity. And that too, this major connector is only indicated in class 3 situation only, not in long edentulous span areas. The acceptance by the patient is excellent due to less coverage of the hard palate. Anterior posterior palatal bar, again, this is again covering very less amount of hard palate, and that is why majorly accepted by the patient. Support and rigidity is compromised, so it has same indications and same contraindications as palatal bar has. So this was all about maxillary major connector. Now after this maxillary major connector, we'll now continue with mandibular major connectors. So the first mandibular major connector is lingual bar. Now this is lingual bar, and this major connector needs the thickness of at least 5 millimeter. So the thickness of this major connector is 5 millimeter, and as we have discussed that the for comfort of the patient or to maintain the health of the soft tissue, the superior borders of the major connector should at least be 3 millimeter away from the free gingival margin. So for this requirement, the space between the free gingival margin and the functional depth of the floor of the mouth or raised floor of the mouth should at least be 8 millimeter. So this space from pregingival margin and the floor of the mouth should be 8 millimeter. Then only we can give or think about giving mandibular lingual bar. So the indication is that wherever sufficient space exists between the functional depth of the alveolar sulcus and the lingual gingival tissue, that is about 8 millimeter, there we can give mandibular lingual bar. Again, the contraindications. The contraindication will be tori. The common situation, the common location where the tori is present is the lingual sulcus below the premolar area. So if the tori is present over here or here, then we cannot give this bar because this bar will cover the tori. So to avoid the coverage of tori, we have to think about other options in mandibular major connector. Second contraindication is that if the 8 millimeter of space is not present between the free gingival margin and the functional depth of the alveolar sulcus, then we cannot give this type of major connector. It provides adequate rigidity and adequate support, and it is mostly accepted by the patient. Now, to know that how much space is there, to know about that whether the 8 millimeter, whether 8 millimeter of space is present or not, we can do one clinical test, that is with the help of the periodontal probe. We'll ask the patient to raise the tongue and to touch his tongue to the hard palate or to the upper lip. And then with the help of the periodontal probe, we can measure the distance between the raised floor of the mouth and the free gingival margin. If it is 8 millimeter or more, then we can give mandibular lingual bar. Otherwise, we have to switch to mandibular lingo plate. Now, mandibular lingo plate is a plate which consists of a bar. Basically, it is a lingual bar only, but it extends up to the cingulum of the anterior teeth. So it does not need that 8 millimeter of space. If space is less, then we can give mandibular lingual plate instead of mandibular lingual bar. Now it is indicated in high lingual frenum or where the space available is limited. It is also indicated for stabilizing periodontally weakened teeth. Now these periodontally weakened teeth are splinted through this mandibular lingual plate. So this is the major advantage of mandibular lingual plate in case of periodontally compromised teeth, because it splints the mobile teeth as well. The other advantage of lingual plate is that it provides excellent indirect retention also. So there are many advantages of lingual plate. It can be given in the cases where there is restricted space present for lingual bar. It can be also given in the cases where the teeth are weakened periodontally, and in the cases where we need more indirect retention, there also it will provide more indirect retention. It also helps in future replacement of one or more anterior teeth. The reason is that it is extending to the cingulum of the teeth. So that is why we can use it for future replacement of the teeth as well. The rigidity and support are adequately provided by this type of design, and it is mostly accepted by all the patients. Sublingual bar is a modification of lingual bar only. So it has the advantages and the disadvantages are mostly the same as lingual bar. Now the next is mandibular lingual bar with the continuous bar. So here is a mandibular lingual bar, this, and this is a continuous bar which is placed over the cingulum of the teeth. So this can be given when we are not able to give linguoplate. If there is a severe undercut on the soft tissue, like in this area, there we might not be able to give lingual plate, because if we give lingual plate in cases of major undercuts, then the insertion and removal and wearing of the removal of the RPD will become difficult for the patient. It can be injurious to the patient. So there, to avoid this problem, we can give mandibular lingual bar with continuous bar wherever the interproximal undercuts requires more block out. Because if we do the block out of the undercuts, then there will be less retention and less support. So there we can use this type of design. It can also be used in case of diastema. If diastema is present, then we'll avoid the metal display between the spaces. From here we can remove the wax up, and when the casting will be done, there will be no metal in between the teeth. So there will be no metal display, and it can be aesthetically accepted by the patient in cases of diastema. Now mandibular continuous bar, that is cingulum bar. This is also indicated when excessive block out of interproximal undercut would be required, but this cannot be given in the cases where the teeth are lingually tilted, because if the teeth are lingually tilted, then this continuous bar, the adaptation of this continuous bar would not be possible. And again, in the cases of diastema, if we give this kind of continuous bar, then there will be display of the metal in between the spaces, which will be very anesthetic. So there also it is contraindicated. The next one is the labial bar. Labial bar is a mandibular major connector which is placed in the labial vestibule. The other major connector which we have discussed till now are all placed in lingual vestibule, but this labial bar is placed in the labial vestibule. So wherever we are not able to give lingual major connectors, these were the situation, will be the situation where we will try to give labial bar. Now these situation can be if the teeth are crowded, if the teeth are very lingually tilted, if there is severe undercut present on the lingual side, or if the mandibular tori are present. In those cases, we need to give labial bar. So I'll read out the indications. It is given in the cases where lingual inclination of the anterior teeth is present, where mandibular tori is present, or wherever there is severe lingual undercuts. But the disadvantage of this type of major connector is that it is uncomfortable for the patient, as the lower lip will be in contact with this metal. So it won't be that comfortable. And the aesthetically also it is a compromised design. There is a modification of labial bar, that is swing lock design, which is given by Dr. Joe J. Simmons in 1963. The modification is that a hinge is present on one side of this design. Here the hinge will be present, and on the one side of the design there will be a latch present. So it can be opened and then can be removed from the mouth, and whenever the patient wants to wear, it can be easily placed in the mouth and it can be locked. So this is one of the modification of the labial bar design only. Now this is all about conventional major connectors. There are other major connectors also which are not rigid. As we have discussed that there is one property, that is the rigidity. rigidity is a major property, but there are non-rigid major connectors also which were designed. So let me tell you about them also in brief. Levin in 1979 has given the rules for selecting the rigid or non-rigid type of major connector. Rule 1 is that if the teeth are periodontally sound and the residual ridge is poor, rigid connectors are indicated. But if the teeth are periodontally weak and the residual ridge is strong, then non-rigid connectors can be given in that situation. The reason is that if we give non-rigid connectors with periodontally weakened teeth, then the force will not be directed to the teeth. It will be only directed to the bone. And as the bone is strong, so it will take up the force. But if in these situations we give rigid connectors, then the force will be directed to the teeth as well. And the teeth are already weak, so they will become more weak. So wherever the teeth are weak periodontally and the bone is strong, there we can think about giving non-rigid major connectors also. The example is split bar major connector is one of the example of non-rigid major connector. The disadvantage of this type of major connector is that the mechanical devices like non-rigid major connectors are free to move independently and are more prone to collect debris and become unhygienic. There also be the chances of tissue trap at the junction between the two parts. So this is one of the major disadvantage of the non-rigid major connector. So this is uh, all about the major connector, one of the major component of the RPDs. So I hope it is well understood. Thank you so much. Take care.